Hi, everyone. Welcome to Cancer Care Ontario Central Region's program on cervical cancer screening. My name is Alan Kaplan. I'm a family doc and the primary care respiratory lead for the group, and we'll be starting in just a couple minutes. Now, we're going to talk about cervical screening and our program and talking about how we can improve it, how we can do it better, and also something new in terms of HPV testing, which I think is going to be very exciting and exciting new change for the future. So in terms of housekeeping, the session is being recorded. I think your camera and microphone are already all off, whether you like it or not. Unfortunately, the chat is not working, but feel free to use the question and answer function to put the questions in. And if there's any issues about your attendance or your connection, then please email Shoshana at the email there below. We're going to be send copies of this in a recording link to all the attendees afterwards for your review. There is an evaluation survey at the end, so please take a moment to do that. That will be SurveyMonkey, not SurveyMonkey, I'm just noticing. And this is accredited for 1 Main Pro credit, so that's the good news for that as well. The Central Region, which is currently located at South Lake in Newmarket, recognizes and acknowledges the lands used and occupied by the First Peoples of the Williams Treaties First Nations, as well as other Indigenous peoples. And on behalf of our cancer program, we'd like to thank them for sharing the land, and we acknowledge also the Chippewas of Georgina Island First Nation as our closest First Nation community. And we have quite a unique relationship with the Chippewas, both clinically in Georgina as well as with their land in the waters of the territory. So they are the water protectors and environmental stewards of these lands, and we join them in these responsibilities. So as I mentioned, this is a 1 Main Pro accredited program, so you'll get that the certificate afterwards. So our objectives really are to talk about changes to cervical cancer screening and manage the referral process and follow-up and surveillance. We're going to talk about cervical cancer prevention, HPV vaccine, and we'll touch a little bit on tools to support you as the people doing the screening to be able to do this in your practice. And of course, cervical cancer is just one of the many things we screen for, including breast, colon, and lung, which is coming. So it's exciting to be able to offer this. So the only clinical thing I'm going to say is this conversation that really HPV is, as you know, is an infection. That infection takes many years to develop into cancer, and only if you've got oncogenic HPV subtypes, and Dr. Lackman's going to talk a lot more about that. But the whole concept of pap smearing is to catch it in the earlier stages when the stages are low grade and a precancerous situation before they turn into cancer. And that's been the principle of cervical cancer screening all these years. So it's a chronic infection. And that's why things in terms of being immunocompromised can actually lead to an increased risk and so on, because you still have to be able to fight off that infection. And many people, as you know, are able to fight off. So what's next? We're going to hopefully be able to, and our cancer team can help you search for patients who are not up to date with their pap smears. There's many tools that we can help you with as well. If you need those help, please reach out. Hopefully, sometime in the future, we make pap smears somewhat obsolete with HPV testing, which our regional cervical cancer lead, Dr. Lackman, is going to talk about. So I'm excited to introduce her to you here today, and I am going to stop sharing and give the floor to Dr. Lackman. So thank you, Dr. Lackman.
Thank you, Alan. I appreciate your nice introduction. I'm just going to start sharing my screen, and slides look okay, Shoshana?
Excellent.
Okay, perfect. So thank you all for joining me on this beautiful summery evening. I join Dr. Kaplan in wishing our Blue Jays a bit more good luck. Maybe by the end of the webinar, they'll be winning. Who knows? I really appreciate you all taking time out of your busy schedules and your personal lives to attend. I hope to be informative and maybe even a little bit entertaining as we take the next hour to journey through the current state of cervical screening and delve a little into the future. I really don't have any disclosures or conflicts to divulge. So tonight we're going to talk about the Ontario Cervical Screening Program. I'm going to give you a snapshot of regional data. We're going to go through the changes to the screening program's recommendations. We're going to talk a little bit about Ask H, because that seems to be a little bit of a black box. We're going to talk about implementation of HPV. I'm going to give you some resources and then hopefully be able to answer all of your questions. So let me just make a little cursor here. Hang on. Laser pointer. So I hope that no one takes offense to this slide. I put it up for a few reasons. The first is hopefully to put a smile on your face with a little lightheartedness. The second is to remind everyone of why we do what we do. We do PAPs to prevent cervical cancer. During the webinar this past February, when I listened to the presentations from the breast and colon cancer screening leads, I was really astounded at the amount of information in all of the screening pathways. In my area, I only need to be familiar with one, with cervix, but you guys need to be up to date on all of them. So I really want to thank you for all of your dedication, your hard work, and your commitment to cervical screening and all of cancer screening. We definitely could not do any of this without you. So cervical cancer is not that common, but it's extremely preventable. And that's why we have a screening program. In 2022, 583 people in Ontario were diagnosed with cervical cancer, and about 155 will die from it. So it's significant mortality. Without screening, these numbers would be much, much higher. Most of these cancers are found in people who have never been screened or who have been screened less often by our current cervical screening recommendations. Cervical screening significantly reduces cervical cancer incidence, so new cancer cases, reduces morbidity like loss of fertility, and reduces mortality. I'm going to touch a little bit on vaccination. So vaccination is not a mandate of the Ontario Cervical Screening Program. It is a mandate of Public Health Ontario. Ontario's school-based immunization program offers publicly funded monovalent HPV vaccines to all eligible grade 7 students. So this is widely available. The sad part is that it's not widely taken. So this slide shows the final dose uptake of the HPV vaccine across the provinces. This is up to date as of 2020. I couldn't find anything more current, likely due to the pause in the school-based programs during the pandemic. But what this shows is that Ontario is at the bottom of the barrel. We have the lowest uptake of the final dose of HPV vaccine in the country. So I think we all need to be cognizant of this and encourage vaccination whenever the opportunity arises. So what is the Ontario Cervical Screening Program? This program is a population-based organized screening program, and the goal of the program is to reduce people's risk of developing or dying from cervical cancer by increasing the percentage of eligible people who get screened regularly and the percentage of people who have timely and appropriate follow-up when necessary. What is timely and appropriate follow-up? This includes referral to colposcopy when required, diagnosis and treatment if necessary, and then seamless discharge back into primary care. So I want to now give you a snapshot of our regional data. So what's happening with PAP test volumes, wait time data, and cervical cancer numbers specifically in the central region. So as you can see from this slide, we have a 52.9% participation rate in cervical screening in our region in the first quarter of 2023 to 2024. The good news is our PAP test participation has actually increased. So we are getting more PAPs done, and that's fabulous. And again, I thank you all for all the hard work that you're putting into this. The problem is that the percentage of our screened population is fairly stable. And the reason for this is because there are always increased numbers of eligible people in the population. So our ratios are staying about the same. But we're on the right track, we're doing a really good job, and we just need to continue doing the work. This slide shows PAP test volumes by year from 2019 to 2023. And we've all seen this big dip in 2020, no matter what we're looking at. But the good news is our PAP tests numbers have really recovered back to pre-pandemic volumes. So our orange line here, which is 2023, is back at the same level as 2019. So we're back on track. We had a surge back in 2022 when everything opened up and we were really, really gung-ho. But now we're back to baseline, which is good. This slide shows colposcopy volumes in our region. So as you can see from the lines, our colposcopy volumes actually remained fairly stable during the pandemic. And the primary reason for that is because we had lower referral rates. We had lower referral rates because there were fewer PAPs being done. So we were actually able to keep the volumes fairly stable. Now that PAP rates have increased, we don't have the capacity to accommodate the increased numbers of referrals that we're getting. And we're going to talk a little bit about this and how we can manage this a little later in the talk. This slide shows, again, in our region, individuals with a high-grade PAP who have not had any follow-up. So we can see that the number of people with a high-grade PAP without follow-up, so without colposcopy, is actually getting higher and higher. And we have tried to address this in our region with various strategies. We're still working on it, but this is a problem that we're seeing actually across the province too. This slide delves a little bit deeper into those wait times. So this slide is showing high-grade PAP test times to colposcopy, and it's divided into 3 segments. The red line is specimen collection date to result report date. And we know that that has gone way up in the last little while, where at one point we hit about a 6-month lag between having the PAP and getting the result. The second bar in green shows result report date to colposcopy date. So back in 21-22, that wasn't such a big difference. But now what we're seeing is that result report date to colposcopy wait time up. And the third is the specimen collection date to colposcopy. And we know that that's an ongoing problem in the province and in our region. But recently, we have seen the report times improve dramatically. And I'm really optimistic that we'll see these numbers go back into acceptable levels as we get timely reporting on PAP data. On this slide, you can see the number of cancers and precancers in our region in 2022. It gives us a little bit of a reality check in that there are significant numbers of people with cervical precancer and even people with actual invasive cervical cancer. Thankfully, precancers are much more common than invasive cancers. But with continued screening and increased HPV vaccination and transition to HPV testing, we will hopefully bring these numbers way down. So let's delve into the recent changes to the Ontario Cervical Screening Program's recommendations for cervical screening. A lot of these changes were introduced in sort of a soft manner during the pandemic, and there's been a lot of confusion about when we're starting, what we're doing, referral times, and so hopefully this will clear things up a little bit. The screening pathways were updated in 2022. The Ontario Cervical Screening Program recommends that primary care providers re-screen people with a first-time LSIL or ASCUS in 12 months. So that was a big change. Previously, if somebody had a PAP showing low-grade changes or atypical squamous cells of undetermined significance, the recommendation was a repeat in 6 months. This 12-month recommendation was introduced, and there are very good reasons for this. There is an exception to the 12-month repeat, though. So the exception to this is for those people with a first-time LSIL or ASCUS if they opt to have an HPV test. So HPV testing is available on a patient pay basis. And if the patient decides to have an HPV test, with a positive result for number 16 or number 18, then those patients should be referred for colposcopy right away. Updates were made to the lab reports in order to reflect these changes. So on the lab report, if somebody has a first-time LSIL or ASCUS, it should say repeat cytology recommended in 12 months. And if they have a second one, if the lab has the appropriate history, it should then say referral to colposcopy. So this is just a snapshot of the screening pathway as it stands now. So anyone with a cervix should be screened at 25 or 21. We'll talk a little bit about that a little later. If it's a normal PAP, continue screening every 3 years. If it's atypical squamous cells of undetermined significance, recommended to repeat cytology in 12 months. If that cytology is normal, repeat cytology again in 12 months. If that cytology is normal, they go back into routine screening. So 2 normals following 1 low-grade PAP, back to routine screening. If those repeat PAPs are either ASCUS or normal followed by another ASCUS or LSIL, refer to colposcopy. And basically the same thing applies to LSIL. So we had an old recommendation that even 1 LSIL PAP could be referred for colposcopy. This is no longer recommended and no longer suggested. LSIL and ASCUS are basically following the same pathways. Repeat in 12 months. If still abnormal, refer to colposcopy. If normal, repeat again in 12 months. And if abnormal at that point, refer, if normal, back into routine screening. As always, any high-grade PAP, ASC-H, HSIL, atypical glandular cells, or adenocarcinoma in situ should be referred to colposcopy immediately. So what's the rationale for repeating the test in 12 months versus 6? So the rationale is for people with a first-time low-grade or ASCUS, repeat cytology after 12 months allows more time for clearance of the HPV infection and normalization of the cytology. And this avoids unnecessary interventions. We know from published data that many low-grade results are likely to resolve on their own within 24 months. Most people will fight off their HPV infection and their results will return to normal. Ontario data shows that the risk of having a cervical cancer is very low for people with a first-time low-grade cytology result. So extending the interval for repeat cytology to 12 months is safe and acceptable. Currently, as I said, HPV testing is not insured in Ontario. It is coming, but for the moment, our current state is that it is not covered, but it is available for some people who decide to pay for it on their own. So it's not actually recommended. It's not recommended because it's not covered, but there's absolutely nothing wrong with doing an HPV test in someone who has an abnormal PAP, a low-grade abnormal PAP, so ASCUS or LSIL. If people decide that they want to have an HPV test, these are the recommendations. So if they are positive for high-risk HPV, subtypes 16 and 18, these can be referred directly to colposcopy. We know that 16 and 18 are the most aggressive subtypes, and these patients need to be seen and evaluated. People who are positive for non-16, 18 oncogenic subtypes can actually safely repeat their cytology in 12 months. So the non-16, 18 subtypes are not as aggressive, and people are more likely to fight off that infection. So they can actually wait another 12 months to repeat their cytology, plus or minus their HPV test. If people are HPV negative, they can return to routine screening with cytology in 3 years. So if someone has a first-time ASCUS LSIL, opts for an HPV test, and the HPV test is negative for high-risk types, they do not need colposcopy. They don't need to be seen in 1 year. They can go back into routine screening with cytology every 3 years. I know I'm spending a lot of time on our current state because it is still our current state. And even though we're hopeful that HPV testing will be initiated, I'm going to say a year because that's what we're hoping for, we still need to know what to do with these patients now. This is a table that actually outlines the cervical screening test results that need referral to colposcopy. And this table is on the decline referral form that some of you may have seen if you've referred a patient for colposcopy and received this back from the colposcopist saying that the patient doesn't need colposcopy at this time. So as always, any high-grade cytology result goes to colposcopy. A low-grade result, ascus or ELSIL, followed by another low-grade result, after 12 months, refer to colposcopy, and a low-grade result followed by a normal, followed by an abnormal, refer to colposcopy. If HPV testing is done, low-grade result with HPV positive 16 and 18, refer to colposcopy. Low-grade result with a repeat cytology test and HPV positive, that also goes to colposcopy. So if you've had a low grade, if you repeat that at a year and it's still low grade with a positive HPV, that needs to go to colposcopy. Ontario Health is encouraging primary care providers to start cervical screening at age 25. This is not the law yet, but it is being encouraged. There is quite good evidence suggesting that people under 25 do not benefit from cervical screening. This is not true, though, for the immunocompromised population, like Dr. Kaplan referred to. So people who are immune compromised, who are or ever have been sexually active and fall into the following categories, should be screened starting at age 21. So it's important to remember, if they haven't been sexually active, they don't need to start screening at age 21, only if they've been sexually active. So people living with HIV or AIDS, regardless of viral load, transplant recipients, people requiring treatment with medications that cause immune suppression for 3 years or more, people with systemic lupus, regardless of whether they are receiving immunosuppressive treatment, people with congenital or primary immunodeficiency, and people with renal failure requiring dialysis. So you have to keep this in mind. It's not a huge portion of our population, but if we have a patient who meets these criteria and they've been sexually active, they should start screening at age 21. For most people, though, screening before age 25 may do more harm than benefit. Early cervical cell changes are likely to resolve on their own in people under 25. People under 25 have robust immune systems. They're really, really healthy. Even if the cell changes don't resolve, they are unlikely to become cancer before someone is screened for the first time, because cervical cancer takes years to develop. So even if someone under 25 starts to have cell changes, the chances of that developing into cancer are extremely low before they turn 25 and start screening. So from 2014 to 2018, only 29 new cases of cervical cancer were diagnosed in people under 25, compared to 2,913 for all ages. The incidence rate of cervical cancer in people under 25 is much lower, 0.3 per 100,000, compared to 8.1 per 100,000 for all ages. Screening people under 25 may result in follow-up tests and treatments that don't benefit them, except for that immunocompromised group, which we just talked about. Many other screening programs recommend starting at age 25 or later, including British Columbia, Alberta, Nova Scotia, and other countries internationally. The Ontario Cervical Screening Program will formally change the age of initiation from 21 to 25 with the implementation of HPV testing. So when HPV testing comes, it will be a formal change and 25 will be the start. We are still encouraging people now to start at 25 because of the reasons that we just talked about. Always investigation of any visible cervical abnormalities or abnormal symptoms, regardless of the patient age, needs to be referred to a specialist, colposcopist, or gyne-oncologist. So I wanted to touch on the management of atypical squamous cells cannot rule out high grade. So this just is a diagram again of management of abnormal cytology results in screening. So our low grade, repeat in 12 months. If normal, repeat in 12 months. If normal, return to 3 years. If abnormal, go to colposcopy. And as always, all high grade results, ASK-H, HSIL, AGC, and AIS, go to colposcopy. The objective of this data was to quantify the baseline risk of HSIL and adenocarcinoma in situ cytology and cancer for people who've undergone colposcopy after a pap test with low-grade colposcopy biopsies or no biopsies without treatment. Okay, basically what this is showing us is that the risk of developing precancer and cervical cancer is much higher for ASK-H cytology than ASCUS. So you can see here, 0.11% versus 1.36% for cervical cancer from ASCUS to ASK-H. And it also shows us that the risk of developing precancer and cervical cancer for ASK-H and HSIL cytology is very similar. So ASK-H is definitely a high-grade result and needs to be sent for colposcopy. Primary care providers might not be managing people with ASK-H cytology as high grade, which could be contributing to the loss to follow-up. So we have a much higher percentage of ASK-H cytology without colposcopy in 6 months, as opposed to HSIL cytology results. And the reason may be that they have similar acronyms. So when the PAP result comes back, sometimes it says atypical squamous cells cannot rule out high-grade lesion. Sometimes it says ASK-H. Sometimes it says HSIL. And so because of the similar acronyms, the ASK as in the ASCUS and the ASK in the ASK-H, it's sometimes difficult to interpret the cytology results in the lab reports. Even I've gotten some back where I have to read it 3 times in order to really pick out, is this ASK-H? Is this ASCUS? And so that may be contributing to this higher percentage of patients with ASK-H without colposcopy in 6 months. Key takeaways: ASK-H cytology should be managed as a high-grade result, and people should be referred for colposcopy. When in doubt, follow the recommended next steps on the lab result report. So the labs are supposed to say what the recommendation is. If an ASK-H result is there, it should say referral to colposcopy is recommended. All right, so let's get into it. HPV testing. So Ontario Health and Cancer Care Ontario has been working very hard for the last very many years to implement HPV testing as part of screening and colposcopy. And I know you've heard about it a lot, and we've been talking about it for years. And at one point we got tired of talking about it because we didn't know when it was coming. However, our projected date is fall next year. So hopefully a year from now, I will be telling you to forget all of the stuff that I just told you about what to do with PAP tests, and we will be talking about what to do with HPV tests. Let's keep our fingers crossed. All right, so let's talk about HPV. HPV infections are extremely common. Up to 80% of sexually active people will have at least one infection with HPV in their lifetime. There are about 150 types of HPVs, 15 high-risk types, and the rest are low-risk types. Some HPV infections can cause abnormal cell changes in the cervix. Evidence shows that most HPV infections are transient, and the associated cell changes will resolve on their own, but this can take several years. Some cell changes will persist, and these are the ones that will lead to cervical cancer if left untreated. So the Ontario Cervical Screening Program will be switching to primary HPV testing for cervical screening. Cervical cytology will still be performed. So the Pap test will still be an important part of our screening. The way it's going to work is a patient will have an HPV test, and if that HPV test is positive, so if they have an oncogenic or high-risk HPV type, cytology will be automatically reflexively performed on that HPV sample. So patients will not have to return to the healthcare provider for another visit. They don't need another cervical swab. This will be an automatic test that's done on any HPV sample that is positive for a high-risk type. Reflex cytology on the samples that test positive is important because the cytology result will provide additional information about the person's risk of cervical cancer. And this will inform us as to whether or not they need to be referred. So an HPV positive test with a normal Pap will have a different pathway than an HPV positive test with an abnormal Pap. It'll let us know who is at higher risk, who needs to be referred to colposcopy for diagnosis and treatment, and who is at lower risk and can just follow up with primary care. As a result of the reflex Pap test or liquid-based cytology, fewer people will be referred for colposcopy, and the ones who are referred for colposcopy are the ones who are most likely to benefit from colposcopy. The cytology will also allow the colposcopist to determine the best way to manage the patient. But the nice thing is it'll be reflexively done. It won't be another visit for the patient. This data is the sensitivity and specificity for detecting CIN2+, so high-grade changes on the cervix. Abnormal cell changes can be caused by both oncogenic and non-oncogenic HPV types. So low-risk HPV types can cause abnormal cell changes. Cell changes can also be caused by other things like infections caused by bacteria or atrophy in our postmenopausal population. Almost all cases of cervical cancer are caused by cancer-causing or oncogenic HPV. So only those high-risk types of HPV will go on to cause cervical cancer. Some of these types of HPV put people at higher risk of cervical cancer than others. The HPV test looks for the presence or absence of oncogenic or cancer-causing HPV and also provides specific information about the type of HPV that they have. So we're looking for the high-risk types, but as you know, most of the labs already will subtype this 16, 18. Some of them also tell us about 45, and then they use the other category. So HPV testing is more sensitive than cytology, and therefore more effective than cytology at identifying people with a cervix who are at higher risk of developing cervical cancer. Sensitivity is the effectiveness of a screening test in detecting a precancer in people who have that precancer, and the specificity is the effectiveness of a screening test in indicating a normal result in people who do not have that precancer. HPV testing is objective and reproducible, whereas cytology is more subjective. Implementing HPV testing in screening and in colposcopy is going to result in improvements to the screening program that will benefit both the patients and the providers. The use of HPV testing in cervical screening will better determine who is most at risk of developing precancer and cancer, and it will help eliminate unnecessary colposcopy referrals. It will free up colposcopy capacity to focus on patients who are most at risk of developing precancer and cancer of the cervix. And it will also avoid the potential harms of unnecessary referrals for patients who don't need colposcopy. HPV testing will also be used in colposcopy and will provide an objective test to determine who can safely be exited from colposcopy back into cervical screening in primary care. And hopefully this will enable more people to be discharged from colposcopy and earlier discharge for some patients than is possible with just Pap testing alone. So it's going to be useful for both screening and for colposcopy and discharge. What this slide shows is the scope of HPV testing implementation. So it's interesting, when I first started as the regional lead, I really didn't have any idea what goes into implementing a new test. But there are so many things that need to be taken into consideration before we can just switch from PAP to HPV testing. There's changes to legislation and regulation, such as changes to the schedule of benefits, fee codes, that need to align with revised screening pathways. The screening and colposcopy recommendations need to be updated. What's the appropriate test? What's the age of initiation? What's the age of cessation? And screening intervals. Procurement of labs to perform the tests and developing comprehensive lab equipment to do the test, as well as procuring an HPV test system vendor. Updates to IT to ensure continuity of key cervical screening functions such as data collection, quality reporting for facilities and providers, and participant correspondence. Establishing robust programs for internal quality control and external quality assurance for the labs performing HPV and cytology tests. Updates to the program for operational activities, updates and development of new materials, educational materials to support providers and public change management. So there's a reason why it takes so long. I think a little hiccup was that, pandemic that we went through for the last few years. Maybe we would have been able to implement sooner. But all of this and more will go into the successful implementation of HPV testing in screening and colposcopy. And like I said, we are aiming to launch HPV testing in the fall of 2024. So again, a year from now, I hope that I will be giving you a completely different webinar, completely different talk, and we'll be able to move forward from there. The approach to developing the future state of the recommendations is based on the concept of risk and risk-based evidence, which aligns with the principle of equal management for equal risk. This approach is similar to the one used by the ASCCP, who've already established their guidelines for HPV testing. So this is a high-level slide, which shows screening and colposcopy populations and what will happen. So routine screening in primary care will actually have 3 intervals. Every 5 years for an average risk patient, every 3 years for an immunocompromised patient, and every 2 years for a moderate risk patient. And depending on those results, the patients will be referred appropriately for colposcopy. They'll have their diagnosis, they'll have their treatment, and then they will be discharged from colposcopy back into screening. And their frequency of screening and how they are followed will depend on how they were discharged and what they need. Again, this is extremely high level. I don't want you guys to focus too much on this slide, okay? So what is the future state? The future state is we will start screening at age 25 in immunocompetent people with a cervix who are or have ever been sexually active. So people who are not have not been sexually active do not need to start screening until they become sexually active. People who have ever been sexually active need to screen even if they are currently not sexually active. The immunocompromised patient, again, is a different group. They should start at age 21 if they have been or they are sexually active. So again, screening is not recommended for anyone with a cervix who has not been sexually active, has never been sexually active, and it is also not based on age of sexual debut. So people who have an early age of sexual debut do not need to be screened earlier than other people. The immunocompromised population is exactly the same as the one we use now. So again, people with HIV/AIDS, people with immunodeficiency, transplant recipients, people getting treatment with immunosuppressants for 3 years or more, people living with lupus, and people with renal failure requiring dialysis. So that group of patients has not changed, and they should start at age 21. So currently we have 2 screening intervals annually for people who are at higher risk and every 3 years for the general population. In the future state, there will be 3 screening intervals. HPV testing every 5 years for people with a cervix who are at average risk. Every 3 years for people who are immune compromised. And every 2 years with HPV positive, not 16 or 18, and normal or low-grade cytology. And that every 2 years will be also including people discharged from colposcopy who are at higher risk. And those people will be defined. So these screening intervals will be well defined and the pathways will be very clearly put out there. A lot of work has gone into when can we stop screening. So we talk a lot about when do we start screening, but when do we stop screening? So currently, and this will apply to HPV as well, we stop screening at age 70 if people meet the criteria. So with HPV testing, people can stop cervical screening if they have had 1 negative HPV test result between 65 and 69, except for people who reach 70 but were not screened in the prior 5 years. They should go up to age 74. Immunocompromised population, they need to go until age 74. And people who were discharged from colposcopy but have not yet met the criteria to return to their routine screening. Again, I don't want you to get bogged down in the ages and the different groups because this is going to be very, very clearly documented and available in our screening pathways. This slide, again gets a little bit more complicated. So if people have a positive HPV test between 65 and 69, they're going to follow the appropriate screening pathways until they get to 74 or until they have a negative HPV test, whichever comes first. People with positive HPV results between the ages of 70 and 74 should be referred directly to colposcopy. So for this patient population, if they need to be screened, even though they're older, they still meet referral criteria for colposcopy, they go to colposcopy. And as always, people with treatable lesions need to follow the appropriate treatment pathways. People without lesions can stop screening and stop their colposcopic investigations. So the next 2 slides, I don't want people to start hyperventilating. I sort of hyperventilate when I see them, but they aren't as complex as they look at first glance. So this is just, again, the pathway for the screening with HPV testing. And most patients will be HPV negative and will follow a very simple pathway. They'll have their HPV test, it will be negative, and they will continue to screen every 5 years. If the HPV test is positive, then that reflex cytology will be performed automatically, and then we just go down the pathways and follow the arrows until we get the patients to where they need to be. Again, I don't want to get bogged down in all the boxes and what to do. It's going to be very clear. The lab reports will say what needs to be done, and we're gonna knock it out of the ballpark. This pathway shows screening recommendations for just the immunocompromised group. Instead of every 5 years, they'll be every 3 years. This pathway is for people who will be discharged from colposcopy. So we know that some of these patients are an elevated risk. They'll have a 24-month screening interval, and they will follow this pathway. So with HPV implementation, some jurisdictions have seen significant increases in colposcopy referrals after implementing the HPV test as their screening test. In fact, all of them have seen this. In the Netherlands, referrals increased from 1% to 3% when switching from cytology to HPV. In Australia, there was an increase in colposcopy referrals. And in BC, in our own country, their trial saw a temporary increase in colposcopy referrals, especially in the 25 to 29 year age group. To help ensure that the implementation of HPV testing in Ontario does not have a negative impact on the colposcopy system, Ontario Health and Cancer Care Ontario is carefully designing the new program pathways, including taking into consideration lessons learned from other jurisdictions. So what we're trying to do is dampen that increase of colposcopy referrals, because we know even now, without HPV testing, our colposcopy capacity is almost at its limit. So you can help dampen the effects of HPV testing on colposcopy by starting to screen people at age 25, as people under 25 are unlikely to develop lesions that will progress to precancer or cancer, and ensure that patients who are referred to colposcopy meet the referral threshold as outlined by the screening program. We need to adhere to the colposcopy best practice recommendations to ensure that we aren't seeing patients at a higher frequency than is recommended. So conservative management at 12 months versus 6 months. This will also create capacity for appropriate post-treatment visits in colposcopy, and discharging patients who can be safely managed in primary care. The Ontario Cervical Screening Program will help support these changes through working with the Ministry of Health to propose changes to the fee schedule for colposcopy, as well as the cervical screening fee codes for primary care. There will be education provided and enhanced colposcopy monitoring and reporting at the regional facility and physician level. So as colposcopists, we are going to be getting our scorecard telling us how well we're doing with discharging patients from colposcopy who can be managed safely in primary care. There are Ontario Cervical Screening Program resources available. These resources are on the Cancer Care Ontario website. I know this is very small, but this is available to anybody who needs it on the Cancer Care Ontario website. These are the current state guidelines for screening. So the future state guidelines, HPV testing, are not published yet. They're not on Cancer Care Ontario's site. They aren't finalized yet, but they will be available when the time comes. And these two letters you may have seen. So this is a decline referral form for a patient who's referred for colposcopy who doesn't meet the referral criteria. And this table here is the one I showed you earlier in the presentation, which outlines the criteria for referral to colposcopy. This form, maybe even more important, is the discharge recommendations after a patient has had colposcopy. So if the colposcopists are doing their job properly, when they are discharging a patient, they should be sending you back this form, which clearly outlines whether the patient is at average risk or slightly increased risk and needs cervical screening every 3 years or every 1 year. And if you're not getting this back from the colposcopist or not getting discharge recommendations after the patients are seen and treated in colposcopy, you should be contacting the colposcopist and asking them to send you better information as to how you can follow this patient once they're discharged. These are both online, and I'm hoping that the colposcopists are using them. I certainly use it in my practice, but it is something that you guys should be seeing more and more of as more patients are discharged from colposcopy. So there you have it. Thank you again for taking the time this evening to participate in the webinar. The new HPV pathways may look daunting, but hopefully once we start using them, they will become as second nature to us as the PAP pathways are now. So thank you again, and I will answer any questions that you guys have put in the chat.
Okay, what a fantastic summary of what's happened and what's coming. So
Thank you.
we'll start with a few questions here. Hi, Michelle. Question here for someone with history of cervical cancer. How often should PAP tests be done, and what's the age of cessation?
That is a great question. So in fact, a PAP test is a very poor way of following a patient who has been diagnosed and treated with cervical cancer, especially if they've had radiation treatment. So for patients who've had radiation for cervical cancer, a pap test will frequently be abnormal due to the radiation changes in the vagina and of the cervix. And so you can get a lot of abnormal pap results due to the radiation. So the best way to follow patients who have been treated for cervical cancer is visualization of the vagina and the cervix. Cervical cancer that's been treated surgically by hysterectomy is after a 5-year follow-up interval, and follow up again with direct visualization. So speculum examination and palpation. If they're 5 years out from their treatment, they're very unlikely to recur. And typically patients with cervical cancer are followed by their oncologist or at the cancer center where they've been treated. So patients who've had radiation typically will be followed out to 5 years at a cancer center, and patients with a hysterectomy as well. But PAPs are not a good tool for following these patients.
Thank you. Michelle's second question had to do with vaccines. I'm not sure if you can answer this, but obviously with all the pandemic delays we've had, someone who's had a first dose at age 12 and a second dose at age 15, do they need a 3-year series? Because now they're talking about 2-year series for those 9 to 14 years old. So how many vaccines should they have?
So if they get the 2 doses, before 14, we know that 2 doses is usually sufficient. But if they aren't in that time frame, they should get the 3rd dose, but it doesn't matter when they get it. So even if they're more than 6 months out, if they're a year out or 2 years out even from that 2nd dose, the 3rd dose is still beneficial. So completing the series, if they're out of the 9 to 14 range, is actually really important. So even if it's 5 years after the 2nd dose, you can still give the 3rd dose.
And aside from that, if they're immunocompromised, does that change the dosing we do for the vaccine?
I don't know the answer to that one. I'd have to find out.
Sorry about that. Just came off the top of my head. So sorry about that, please. All right. So I think right now the answer is no, but actually as we talk about it, perhaps we should actually be spending more attention, especially to young people immunocompromised. But anyhow, question from Elena about if someone's had 2 ASCUS results and both HPV tests conducted 12 months apart are negative, so they've had abnormal cytology but negative HPV, what should their screening be after that?
So in the current state, if they have a negative HPV test, they should go back to routine screening every 3 years. So even with a first ASCUS, if they had an HPV test in conjunction with that, they don't need another one in a year. A negative HPV test in our current state returns a patient to every 3-year screening. So negative HPV test, regardless of low-grade cytology, is back to routine screening. If a patient has high-grade cytology and an HPV test was done for some reason, doesn't matter what that HPV test shows, they need to go to colposcopy. So there is a false negative rate for HPV testing. If a cytology shows high-grade changes, whether it's ASK-H, HSIL, AGC, or AIS, those 4, it doesn't matter what their HPV test shows, they need to be seen by colposcopy. So that's important to remember. I've had a few patients in my practice, negative HPV test, high-grade changes on the cervix. Needing the LEAP, they've had precancer changes. So be careful with that one. But with low-grade cytology, negative HPV test every 3 years.
And I think that just emphasizes how we're using both of these tools to make our decisions rather than just one. That's really important. I got one other question that's come up to me is if we're going to move people to 25 and the government currently pays us based on the percentage of as primary care doctor and primary care models, the percentage of patients who are having their proper screening, that's going to be a potential issue to our primary care colleagues getting paid, because if you start at 25, a group of your patients will not be done within the recommended timeframes that are currently being suggested. So any comments about that other than being frustrated like me?
So changes to the fee schedule are coming. So with HPV implementation and with the recommendation to start at age 25, those issues should be dealt with. Because though that's part of the implementation process, it's actually changing the schedule benefits.
Mm-hmm. But right now, guys, if you're going to move it to 25, which Dr. Lackman has suggested, for the very good reasons. I guess we're just going to have to recognize that our percentages may fall a little bit in terms of our payment. One more hit for family doctors across Ontario.
That's
Anyhow,
that's intention.
that's not,
that.
and it's not your fault at all. It's not your intention. It just shows that it's hard to get the fee schedule changed, as I think we all know. It's been discussed, and it's been pointed out to OHIP many times by many of us already, that this is an unfair punishment to primary care docs who are doing their job properly. But anyhow, such that it is. All right. Well, I think that ends our questions. If anyone else has any questions, quickly type them in. Otherwise, I'm going to return all of you 5 minutes of your time. Do you see something I don't see?
Yes, Dr. Lackman and Dr. Kaplan, if you take a look in the published section, I think you'll see a few more questions coming through.
In the what section?
In the published section. I see it here. So there's a question about vaginal vault smears in endometrial cancer. So a little bit outside of the scope of this talk. However, I'm going to answer it. So vaginal vault smears in patients who underwent a hysterectomy for endometrial cancer are not recommended and not useful. So following patients with endometrial cancer, once again, it's a direct visualization of the vaginal vault with a speculum, but not a pap test. These patients do not need cervical screening. They don't have a cervix. I hope that answers that one. There's a question from Tara. Hey, trying to start PAPs as well. I'm looking forward to. Is it a question? No, it's just a comment. Thank you, Tara. Is there an age cutoff for recommending the vaccine? Oh, there's the question. Okay. So again, I'm outside of my scope here, but I'm going to answer it anyway. So the vaccine is useful for anyone who may be exposed to HPV. All right. The best time to get the HPV vaccine is before any exposure to HPV. And that's why grade 7 is the target, because hopefully these children will not have been exposed to HPV yet. But if someone is older and they have a potential to be exposed to a new HPV infection, there's absolutely no reason why this vaccine would not be appropriate for them. So you could even have a patient who's in the 40s or 50s who may be on the dating scene and may be exposed to new HPV. There's no downside except the cost. So that is the negative of the HPV vaccine. It is an expensive vaccine. It's $200 a shot, 3 shots. So that's a concern for some people. But in terms of an age cutoff, I do not have one. If someone's at risk for HPV infection, the vaccine is probably going to help them.
So my only addition to that is that, remember, as I showed with my very first slide, it takes 15-20 years for this whole thing to occur. So if you've still got 15 or 20 years ahead of you, and you've had a new exposure, then theoretically you're at risk. And of course, the older you are, the less your immune system works, the more likely that an oncogenic strain might actually cause trouble. So I think you're looking at that 15-20 years down the road as probably whether or not it's worthwhile to give the vaccine. But certainly we're seeing lots of people now who are, as you say, getting back into the game, perhaps with a change in spouse or a change in lifestyle or whatever. There was another question about screening a 20-year-old who has symptoms, and I think you answered that clearly before. If somebody has symptoms or a visual abnormality, they require a referral to colposcopy or assessment of those symptoms.
Absolutely.
And then the last question was, I've had patients with, and hi Dina, I've had patients with HPV, quote, other and negative or low-grade PAP who seek colposcopy against this doctor's recommendation. Then they have HSIL, found a colposcopy biopsy. So would the lesions likely have resolved if they'd waited? So now you have to be soothsayer as well, but I think you've got a pretty good answer for that.
So it's unusual if you have a negative or low-grade cytology to have a high-grade lesion found at colposcopy. However, we know our tests aren't perfect. We know that it can happen. We know there are always exceptions to the rule. We know there are patients who don't follow the rules. And so it doesn't change our basic recommendations for our population-based screening. Population-based screening is based on the general population. If we took all of the exceptions, we'd be screening people. when they at their sexual debut, because we know cervical cancer still can happen in people under 25. I've seen it in my practice, but it's outside of our regular HPV natural history. And so would these lesions have resolved? Unlikely. You know, I can't answer that question.
And again, the point here again is there's going to be those cases that are outside, and the screening program is going to capture the majority of cases. You can't screen for the unusual situations. There's no way you can have an effective screening program. So that's really why that's going to end up being those unusual ones are going to be things you actually can't predict.
Tom had a question. Is there a role for HPV? Hi, Tom, by the way. Is there a role for PAP or HPV, regardless of age, in a symptomatic patient? If a patient has bleeding, if they have an obvious cervical lesion, they need to be seen and referred. And in my practice, regardless of whether a PAP was done, so if you've seen a patient with a cervical lesion do a PAP and the PAP is normal, that's not going to change my evaluation of that patient. I'm going to still see them in colpo. I'm going to still biopsy that lesion. And so the PAP at that point may not be very useful. The HPV test, it may or may not. But again, with a visible lesion and an abnormal cervix, that needs to be evaluated regardless of those test results. So even with a negative HPV, Tom, I would still biopsy and see the patient in colpo. It may help after the patient is treated to evaluate their risk going forward and their screening intervals going forward. But in terms of diagnosis, if you have a symptomatic patient, I don't necessarily think that those are useful tests.
Excellent. Okay, everyone. Well, it's just after 7:30. I don't think I'm seeing any more questions here, team. I don't think so.
I think we got them all.
All right. So excellent. So thank you for being so clear and cogent with your answers and your presentation. I've learned a lot. I'm sure all our attendees have as well. If you do have questions, first of all, you're going to get a copy of this recording sent to you. If you do have any questions about cancer screening, please don't hesitate to reach out to me or to the team. And I look forward to the rest of the evening. And I hope when we turn the TV on after this, the Blue Jays have come back from their deficit. That might be wishful thinking. So the best to everybody. Good night. And thank you to Shoshana, Ashley, and everyone for arranging this. And once again, Dr. Lackman for the wonderful presentation. Have a good night, everybody.
Thanks, everyone.